So I am going to talk on the heart failure. A breakthrough in heart failure management, evidence supporting research-based molecules. I am Professor Rajkumar. So these are some glimpses which CardioCon was held at Sakhar in my city in 2023. So breakthrough in heart failure. Naturally, when we talk of the heart failure, then there are a lot of things which we have to think of. First of all, foremost, which comes in our minds is pharmacology. Then there is Dr. Saiba on device-based therapy. Then telemedicine nowadays, emerging trends, and then biomarkers. So this is the arbitrary deviance that we have divided heart failure into the reduced ejection fraction and preserved ejection fraction, and then in between there is mid-range. So these are the guidelines, the diagnosis and treatment of acute and chronic heart failure by ESC and 2022 guidelines of American Heart Association. All what do they say? The pillars of the drug therapy for heart failure with reduced ejection fractions, 5, alive or fantastic 4. The SE inhibitors we have been using since long are the ARBs, and when they are included latest model, that is combination of SE inhibitors and neprilysin inhibitor, that is ERNI, and beta blocker, mineralocorticoid receptor antagonist, SGLT2 inhibitors. So all those ESC, especially if you see that all about 3 are given class, 4 are given class 1 and level A, that they must be used and them as per individual's presentation and the markers. So angiotensin neprilysin inhibitors versus enalapril, if you see there are paradigm heart failure trial, it has given a good evidence that they are working more and reducing the hospitalization, as well as you can see that there is decrease in mortality in comparison to the ARBs, SE inhibitors, then it has age. So again, SGLT2 inhibitors enable to patients with heart failure with reduced ejection fraction. There are cardiovascular and renal outcomes with empagliflozin in heart failure. So if you can see over this that there is very much reduction of the primary endpoints, that is composite of cardiovascular death or heart failure hospitalization. First secondary point, that is total first and recurrent heart failure. Secondary endpoint, that is slope of decline in glomerular filtration rate, and there is very remarkable decline with the use of the latest drugs. So another drug, that is eplerenone, if you see that there is also as compared with the placebo, it has got an age that it reduces both the risk of death and the risk of hospitalization among patients with systolic heart failure and mild symptoms. So the 3 fundamental changes in approach to the treatment. Speed matters. We have been too slow in introducing life-saving therapies in the past, and initiation versus dose titration, if we see, prioritize initiation over up titration of the dose and order sequence of therapy. Still there are doctors who are using SE inhibitors and the severe heart failure, whereas there are latest drugs and the evidence is there that there is no fixed order, no preference for the sequence used, so the treatment is individualized. So we need to move away from this approach. Initially we used to start with the SE inhibitors, ARBs, then beta blockers, MRAs, neprilysin inhibitor, SGLT2. So this was a vertical stepwise, कहते थे हम titrate करें पहले initially first dose को to the maximum, then go on adding other things. So this delays the initiation of life-saving therapies that are immediately beneficial. So there are complementary therapies acting the distinct pathophysiological pathways. So the goal is to implement as many as possible, quickly as possible, as ROS blockers, SGLT2 inhibitors, MRAs, beta blockers, and neprilysin inhibitors. So step 1 medication may be started simultaneously at initial low doses recommended for heart failure with reduced ejection fraction. Alternatively, these medications may be started sequentially with sequence guided by the clinical or other factors without need to achieve target dosing before initiating next medication. Initially we used to follow the pattern that एक drug को हम ऊपर ले जाएं maximum dose पे then add करें. So this is not now. So these are the recommendations for renin-angiotensin system inhibition with SC inhibitors or ARBs. Referred studies that support the recommendation are summarized in this. So this is a detailed, a busy slide. Because of the time, I move on another slide. And if you look all those in patients with chronic symptomatic heart failure with reduced ejection fraction, NIHA class 2 or 3, who tolerate an SC inhibitor or ARB, replacement by an RNA is recommended to further reduce morbidity and mortality. So in patients with chronic symptomatic heart failure with reduced ejection fraction, treatment with RNA instead of an SC inhibitor provides high economic value as well. So again, this is SEC and Heart Failure Society of America says that in patients with heart failure with reduced ejection fraction, it does not necessarily need to be done according to the sequence of trial publication, and it should not be delayed. So this is regarding the SGLT2 inhibitors, heart failure trials, ambulatory patients. If you see DAPA heart failure trial and deliver heart failure, there is remarkable improvement in the hospital heart failure hospitalization and cardiovascular death as compared with the placebo. And again, pharmacology treatment for heart failure, reduced ejection fraction and mid-range or preserved ejection fraction. If you see, then SGLT2 inhibitors have an age. So meta-analysis of the pharmacological agents in heart failure with reduced ejection fraction in a meta-analysis of 75 randomized controlled trials looking at the pharmacological agents in heart failure with reduced ejection fraction, the highest reduction in composite of cardiovascular mortality and heart failure hospitalization and in all-cause mortality was with combination of ARNI, beta blockers, MRAs and SGLT2 inhibitors. So, and look at the last line that ARNI was associated with the largest reduction in all-cause mortality followed by MRAs and SGLT2. I think most of our cardiologists will agree with me that I have myself found in my clinical practice that ARNI has a remarkable age in improvement of symptoms and heart failure hospitalization. So again, this is a busy slide that it says that initiation of oral guideline directed medical therapy during hospitalization for heart failure is associated with numerous clinical outcome benefits. Roughly 42% of patients are not prescribed guideline directed medical therapy within 30 days post-index hospitalization, and 40% are prescribed either no oral guideline directed medical therapy or monotherapy within 1 year post-hospitalization. So this is an alarming that we should work on, and we should think of that we should follow, and we should train our juniors to properly hammer. Because the heart failure is, I believe that it's a serious than the cancer. If you have cancer in any part, you can get rid of. But once you are caught into the heart failure, you will remain and you will be suffering. So this is paraglide heart failure trial. It says that ARNI in worsening heart failure with mildly reduced ejection fraction. I will, because of the time, I will go on the, these were the primary and secondary objects. So let me share that the expert adjusted incidence rates of serious adverse events were found to be 103 for both the sacubitril/valsartan and valsartan groups. Sacubitril/valsartan group had demonstrated a lower incidence of worsening renal function and more symptomatic hypotension when compared to the valsartan. Hyperkalemia events were similar between the groups. So sacubitril/valsartan group showed fewer hypertensive related serious adverse events. Only one case of angioedema was observed in valsartan group. So now it is the time of tele-rehabilitation. So I think there is talk on this. So if you see, then we have to also follow the latest things which are coming. So artificial intelligence, that also very much helpful, and I think everybody should apply all those in our practical practice, because it is very helpful. So the conclusion, both the 2021 and 2022 ESC and American guidelines firmly established the 4+ strategy for heart failure management: ARNI, beta blockers, MRAs, and ST2 SGLT2 inhibitors, first ever recommended for heart failure with mid-range ejection fraction, reduced ejection fraction. New therapy for heart failure with preserved ejection fraction. Still trials are going on, the SGLT2 inhibitors. Very important change in approach to use the therapies of heart failure with reduced ejection fraction, speed and sequencing, because in olden days we were too slow, but now the data are there, so that is why we should follow that. Very important change in approach. So continuation of oral guideline directed medical therapy during hospitalization lowers the risk of post-discharge death and readmission among a diverse population with ejection fraction more than 40% stabilized after recent episode of worsening heart failure. Patients on sacubitril valsartan saw greater reduction in NT-proBNP than those on valsartan through 8 weeks. That was a paraglide trial. So thank you very much.